Kotzé is a general dentist who grew up in the small town of Bloemfontein. He completed his high school education at Grey College. Dr. Kotzé graduated from the University of Pretoria in 2019. Thereafter, he did his community service in Potchefstroom. He also, I must mention, graduated with cum laude. Must never not mention such achievements. Well done, Dr. Kotzé. Thereafter, he observed the internship under Dr. Peter Bukes in his free time. This is where he states that Dr. Bukes contributed his love for his microscopic dentistry and usage of the rubber dam isolation technique. In 2021, he started working in private practice, and in 2022, completed his postgraduate diploma in endodontics at the University of Pretoria, yet again cum laude. In the same year of 2022, he states he got the opportunity to purchase a dental operating microscope, which then opened up a new world. Our second speaker, Dr. Hendrik de Pinaar, is currently working as a general dentist, but also expresses a special interest in endodontics. Dr. de Pinaar finished his degree at the University of Stellenbosch in the year of 2002. He was then awarded with the FX Prince Award for the best student in clinical dentistry. Wow. After his community service year in 2003, Dr. de Pinaar started a private practice in his town of birth, Welkom. I'm assuming that's located in Gauteng. He served on the solder board for the Free State, ranging from the year 2004 all up to the year 2008, and he became the president in 2008. He's presented over 100 lectures locally and internationally. In 2019, Dr. Hendrik de Pinaar won the Battle of Speaker competition in South Africa, and he, as he says, expresses a special interest in endodontics. And in the same year of 2019, he relocated his practice to Platinumberg. Right. Just a few announcements for the viewers. Just make sure that you do not raise your hand throughout the lectures and that you slip in any questions or inquiry in the Q&A tab. You will be able to receive your CPD certificate through the platforms that are located, and this lecture will be equivalent to 1 clinical point. Right, Dr. Charel Kotzé, please do take the stage. Thank you.
Thank you very much, and I want to thank Sarah for this opportunity to present you all a lecture tonight on a topic that I'm really passionate about, and that topic is endodontics. And I want to also thank Dr. Heinrich for being here tonight. It's really a great privilege to have you here with us. And I also told Dr. Heinrich the first SARA Congress I attended was back in 2018 when I was still a 4th-year dental student. Now, Dr. Heinrich did a lecture on microscope dentistry and magnification, and that was really inspirational for myself. And the type of work I do today is really inspired by him. So I want to thank him for the influence he's had on me and so many other dentists in South Africa. So thank you, Heinrich. So I just want to share my screen now for the lecture.
Charles, just maybe as a question, because I will only be doing a Q&A at the end of the webinar. So please feel free to, that you don't interfere while busy presenting. And at the end, there will be a half an hour of Q&A, and then between you and myself, we will answer it. So please, all the participants, feel free to post in the Q&A throughout the lecture, and then we can answer it at the end.
Yes. Just want to see. So like I said, tonight I'm going to talk about endodontic tips I wish I knew at the start of my dental journey. Now, before I start with this lecture, I want to tell you all the story of how I fell in love with my biggest fear. Now, in our final year at university, the practical quota required for endodontics was only 5 molar root canal treatments. Getting into my community service here, I only had exposure to doing extractions because there was no equipment to do any restorative or endodontic work. Getting into my first year of private practice, as you can imagine, doing endodontics was really stressful as I had no experience or exposure doing endodontics. But as the year went on, I gained more experience and confidence. And I remember I did an emergency root canal treatment on an upper maxillary tooth. I made my access cavity, and in the middle of the tooth, I saw pinpoint bleeding. It really got me excited as I thought I found my first MB2 canal. Needless to say, I actually perforated the tooth and the tooth needed to be extracted. Right there and then, I decided I will need more education on endodontics. So that's when I decided to enroll in my postgraduate diploma in endodontics. And I also had the opportunity to buy myself a dental operating microscope that same year. Now that really changed everything. Nowadays, I enjoy doing root canal treatments and I get excited when my patients tell me they want to try and save their teeth. Now, the reason why I tell you this, most of you ComServe, post-ComServe is in the same situation. You don't have a lot of experience doing root canal treatments and it is really a great stress. But don't dwell on mistakes like perforating a tooth because you're going to make some mistakes. But let it really be inspiration for you to strive for excellence and actually strive to learn more because it will get better. So that's how I actually fell in love with my biggest fear. Now, the aim of this lecture is to provide you with some tips, and we're going to work through an endodontic workflow. And at each step, I want to give you tips that you can apply to your own endodontic workflow. Now, this is the workflow that we're going to work through. We're going to start off with the history taking. Be a Sherlock Holmes. A Canadian physician named Sir William Osler once said, "Listen to your patients, they will tell you their diagnosis." But as we all know, our patients are very stressed and anxious when they sit in our dental chair, so they won't tell you all the information you need to know in order to make a proper diagnosis. You literally have to be a Sherlock Holmes to get information out from your patients. Now, something that we often neglect asking our patients are trauma-related questions because patients don't relate the traumatic incident that occurred on their teeth when they were younger to be the cause of a dental problem they sit with now. So just keep that in mind as I will show you a case later on. Moving on to our clinical examination. You can't treat what you can't see. Now, I know we all know how to do proper pulpal test, percussion test. We even know how to palpate tissues around teeth. But something that we often neglect doing is just examining the tooth as is. And the only way to properly examine a tooth is with the aid of magnification. Now, magnification will allow you to see detail that you will miss with your naked eye. And the most common dental pathologies that we all know is carious lesions in periodontal disease. But something that we often miss, and that's actually a very common pathology, is cracks in teeth. And the only way to diagnose and treat cracks is with the aid of magnification. Now, let's look at the different types of magnification that one can get. The Rolls Royce of magnification, like we all know, is the dental operating microscope. The dental operating microscope will allow you to magnify your field by up to 20 times magnification. We also get dental loops, and nowadays we get very sophisticated loops. We get ergonomic loops, which help to sit you upright in an ergonomic position and just to look straight forward. You don't have to bend down your neck. And with these loops, you can get anything from up to 10 times to 12 times magnification. Another tool that you can use is an intraoral camera. Now, an intraoral camera is more used for documentation, but it can also be used to take pictures and magnify that picture in order to get some magnification. Now, I know in the beginning of our dental career, we don't want to necessarily make the expensive investment in all these equipment. but I would definitely advise you guys to invest at least in loops. Start off with a 2.5 or a 3.5 Galilean type of loop, just to get used to magnification. And as you get used to it, you can make more expensive investment in more expensive equipment. But I want to show you something that we all use every day, which is dental mirrors. Now, I don't know if you know what type of dental mirror you are using, but there's actually two main types of mirrors. We get rear surface mirrors and front surface mirrors. Now, with rear surface mirrors, as the name states, the mirror is at the rear and is actually a piece of glass on top of the mirror. Now, the problem with this is that you get secondary images or ghost images, as they call it, because there's a reflection from the mirror as well as the glass slab. Whereas with a front surface mirror, you get a lot more detail because there's no glass slab on top of the mirror. You just get one image. Now, to show you a clinical example of this, on the left-hand side, you can see that's a rear surface mirror. On the right-hand side, a front surface mirror. Now, if you put a probe on a rear surface mirror, you can see there's that gap. And that gap is actually your glass slab. And on the right-hand side, that's a front surface mirror. And when you put the probe on, there's no gap. Now, just look at this clinical example of this mandibular molar. If you look at it under a rear surface mirror, you can't see a lot of details. You can't even see all the canals that are present. But with a front surface mirror, there's so much more detail. You can see clearly how many canals there are. So it's much more detailed. So I would really advise you all, if you do restorative work or even endodontic work with root canal treatments, try and use a front surface mirror. The only drawback about a front surface mirror is that it scratches quite easily. So don't use these mirrors for your scale and polish procedures because it will scratch, but definitely use it for restorative and root canal type of procedures. Let's look at the clinical case. Now, this patient came in with pain associated with tooth number 4-6, and on the periapical radiograph, you can see there was a periapical lesion associated with this tooth. And on the bite wing radiograph, you can see there's a small interproximal carious lesion, but no obvious deep carious lesion or a very deep filling that would justify this periapical area. So we actually expected a crack in this tooth. So we administered our local anesthetic, placed our rubber dam isolation, and in the distal part of the tooth, you can see there was a crack. Now, bacteria went down this crack, causing the interproximal carious lesion, which we call occlusal effect caries. There was also a carious lesion on the neighboring tooth. And now you can see we actually tried to dissect the crack. We followed the crack, and the crack went right into the pulp, causing the necrotic pulp. The crack extended right down the root, and unfortunately, the tooth needed to be extracted. Now, what I want you to notice on this image is actually how the periodontal ligament detached in the area of the crack. So just see the area where the crack is, there's actually periodontal ligament attachment loss. Now, this is quite important because keep this in mind, because we can't see cracks on x-rays like you just saw, but sometimes we can actually see the effect of a crack on an x-ray. So just keep that in mind. Let's move on to our radiographic examination. Now, before I start with the radiographic examination, I want to show you all a video. Count how many times the players wearing white pass the ball. So count how many times the players wearing white pass the ball. So how many times did the players wearing white pass the ball? The correct answer is 16 passes. But did you spot the gorilla? Now I want to show you all the video again because I don't know how many of you actually spotted the gorilla. So let's just go back. Now the reason why I show you this video is sometimes we are so focused on how many times the players wearing white pass the ball that that's all that we see. We are so focused on seeing how many times the players wearing white pass the ball that we actually miss something very obvious, like a gorilla passing through the frame. So just check this. There was actually a gorilla passing through the frame and stomping on his chest. And this brings me to my next statement. You only see what you look for. Now, we as dentists are so focused on looking at teeth and so focused on seeing cavities that what we only see on x-rays are cavities. We really need to examine our x-rays in full. We need to examine the periphery of our x-rays. We need to examine the bone of x-rays. We can't just look at teeth, because if we just look at the teeth and we are so just focused on seeing cavities, we actually might miss the gorilla in the room. Now let's look at a few clinical cases. This panoramic x-ray was taken for a patient that came in with a main complaint of a fractured front tooth. And as you can see, tooth number 1-1 had a fracture. There's also fractured teeth 1-4, fractured teeth in the third quadrant, 3-6 and 3-5. Let me just indicate with the cursor. And you can see there's also most likely a root rest where tooth number 4-6 was extracted. But what I want you to notice is actually the radiopaque lesion associated with the right carotid artery. Now that could be a right carotid artery calcification, and this should prompt you to refer your patient to a medical physician, as something like this can lead to a stroke. Now, if we are so focused on looking at the teeth and looking at cavities and carious lesions, we might miss the gorilla in the room. And the gorilla in this room is actually the right carotid artery calcification. So be vigilant. Don't just look at your teeth, look at the periphery of your x-rays as well. Looking at another panoramic radiograph, this patient came in with pain associated with tooth number 2-7. And what else can you guys see on this x-ray that's out of the ordinary? We could argue that there is most likely a radiopaque lesion between tooth number 3-5 and 3-6, which could be something like idiopathic osteosclerosis. But what I want you to notice is actually the pulp canal of tooth number 3-1. Can you see that this pulp canal is much more obliterated compared to the neighboring teeth? And when we took a periapical radiograph of this tooth, you can see that this tooth actually had pulp canal obliteration, or as we call it, calcific metamorphosis. And when we took an intraoral camera photo of this tooth, you can see that this tooth appeared much yellower in color compared to the neighboring teeth. Now, I asked this patient if he ever noticed that his bottom front tooth is getting more yellower in color, and he acknowledged, and he told me he really wondered why it's happening, but he never knew. So after asking him a few questions, we got to the conclusion that he actually had a traumatic rupture incident when he was younger. And that was the cause of this presentation of this tooth. The trauma of the tooth caused the canal to obliterate, and because it obliterates, there's more dentin deposition, and that's why you would see this tooth appearing more yellow in color. Now, this brings me back to my history taking. We have to be a Sherlock Holmes, because if we don't ask our patients a lot of questions, they won't tell us these stuff, because our patients are so stressed, they're usually in pain, so they don't think of these stuff. So it's really important to be a Sherlock Holmes and to be really investigation and do your investigation and ask your patient a lot of questions. Now, what's really important about teeth like this that present with pulp canal obliteration is that you would do a pulp test, but it will not react like your normal teeth would react. But remember, this should not prompt you to do a root canal treatment. If this tooth is asymptomatic and there's no periapical lesion on this tooth, you shouldn't do anything. You can just monitor this tooth. Looking at another clinical case, this patient I saw in my first year of private practice. I took a periapical radiograph, which is not really a good periapical radiograph. Needless to say, we took it and we saw there's a carious lesion on tooth number 1-1, and there was also secondary caries on tooth number 2-1. So I placed both of the restorations, and 2 days later, the patient's mother called in to inform us that the patient's or the child's face was swollen. And I really got stressed. I got the patient back in and I took another periapical radiograph. Now, this is to show you the importance of when taking periapical radiographs to get at least 2 to 3 millimeters beyond the radiographic apex. Now, that's not just for endodontic treated, if you want to do a root canal treatment on a tooth, that's even for restorative work. So really focus on, and when you take a periapical radiograph, make sure that you get at least 2 to 3 millimeters beyond the radiographic apex. Now, the reason why this patient's face was swollen is because of the local, and it could be due to the local anesthetic administration in the area, which caused pressure buildup, or it could be due to the leaking restoration that we replaced on tooth number 2-1. Now there was no corona leakage and all the pressure was built up apically, and that's why the patient's face was swollen. Now, luckily, the principal dentist at the practice did the root canal treatment, and you can see how lovely the lesion healed. But this is once again to show you, because I can promise you it's not always easy to get 2 to 3 millimeters beyond the radiographic apex, especially if we take periapical radiographs of mandibular teeth or even upper maxillary teeth. So make sure that you get 2 to 3 millimeters beyond the radiographic apex. Looking at another periapical radiograph, this patient came in with pain associated with tooth number 3-7. There was also a periapical area on this tooth, and this patient was really in a lot of pain. As you can see, no obvious carious lesions, no deep fillings. So what was the cause of this patient experiencing pain? Now, like I said, we can't just focus on teeth. Just look at the bone. I don't know if you guys noticed that there's actually a vertical bone defect on the distal part of this tooth. So right in that area, there's actually a bone defect. We extracted this tooth and you can see there was actually a very big vertical crack associated with the distal part of this tooth. Now, like I mentioned before, we can't see cracks on x-rays, but we can sometimes see the effect of a crack on an x-ray. So due to the crack being in the distal part of the tooth, there's actually periodontal ligament attachment loss associated with the crack, and that's why we see the vertical bone defect. So because the crack is running right down the distal part of the tooth, there's a vertical bone defect. So this is really important when you're taking a periapical radiograph of a tooth and you can't see an obvious deep filling or a deep carious lesion. You should think there's most likely a crack on this tooth and examine the bone, because the bone can sometimes give you a clue that there's actually a crack extending right down the root. Now, what's really important when taking and doing an oral examination for our patients, when doing an oral examination for our patient, focus on your 3-7 and your 4-7 distally, because that's really where I see cracks on virgin teeth. And the reason for that is most of our occlusal forces are usually concentrated at the very, very back of our teeth. It's almost like a nutcracker effect. So most of the occlusal forces are at the very back of our jaw. So examine, when doing an oral examination, inspect the distal part of your 3-7 and 4-7 and look at cracks, because these cracks are usually seen on virgin teeth. Moving on to our diagnosis. Now, the cause behind the diagnosis is actually more important than the diagnosis itself. It makes no sense in treating the diagnosis but not treating the cause behind the diagnosis. It's more important to understand why the tooth has a necrotic pulp or why the tooth has an irreversible pulpitis. Because if you just treat the symptoms, the patient will feel better, but 1 year down the line, the tooth might just fracture or the pain might reoccur. So it's really important to understand what's the cause behind the diagnosis. Now, to explain to you this better, let's look at a clinical case. This patient came in with pain associated with tooth number 2-6. You can see there's a periapical lesion associated with this tooth. There was a composite restoration in the mesial aspect of the tooth, as well as a amalgam restoration. And you can see there's a radiolucent lesion in the mesial part of this tooth. Now that was actually a mesiopalatal cusp fracture. Now let's look at this tooth. The first thing we did, we removed the amalgam restorations. And now all of a sudden you can see there's a lot of cracks associated with this tooth. There was vertical cracks as well as horizontal cracks. Now, horizontal cracks usually result in cuspal fractures, where vertical cracks are usually more detrimental in state. And this vertical crack went right into the pulp. And there you can see that's after removing all the cracks, dissecting all the cracks, and we placed a composite restoration. Now, we did this before we even started treating the tooth on the inside, because like I said, it makes no sense in doing the root canal treatment, but not removing the cause. And the cause in this case was actually the cracks. So it's really important, if a tooth has cracks, you want to actually dissect and treat the cracks before you even start working on the tooth on the inside. It's like doing a root canal treatment, but leaving the carious lesion. It makes no sense. We have to remove all the carious lesion before we start with the root canal. Exactly the same with cracks. You have to remove the cracks before you start to treat the inside of the tooth. Moving on to our local anesthetic administration. Heat it up. Now, the biggest reason why our patients experience pain during local anesthetic administration is the reason because we inject a local anesthetic ampule of room temperature, which is 20 to 25 degrees Celsius. And nowadays, when it's winter, it's even worse. We inject that into a body temperature of 37 degrees. Now, that change in temperature causes the stinging sensation and the stinging pain that our patients hate. So what you can do is you can actually heat up your local anesthetic ampule. So the most easiest way to do this and the most effective way to do this is with the aid of a baby bottle warmer. Now, a baby bottle warmer like this, you can buy at Clicks for only 250 Rand, and you can use it to heat up your local anesthetic ampule, but you can also use it to heat up your irrigation solutions. Now, there was a study done to see the effect of heating up your irrigation solution. So they saw that heating up a 1% concentration of sodium hypochlorite to 45 degrees Celsius is just as effective in removing pulpal tissue than a 5.25% sodium hypochlorite concentration at 20 degrees Celsius. So really invest in a baby bottle warmer. Your patients will really love you for it because you will give less painless injections and you will actually get more efficiency from your sodium hypochlorite. Moving on to our isolation. Now, rubber dam isolation is really a must with root canal treatment. And sometimes it feels like telling dentists to place rubber dam isolation, it feels like telling patients to start to floss every night. We all know we should do it, but we don't. And I can bore you with all the advantages that rubber dam isolation has, but the biggest advantage it has for myself, it really gives you a peace of mind. I can work in absolute comfort. I don't have to stress about anything going down my patient's throat. And the other important advantage it has for myself is that it actually keeps your tooth dry. And when your tooth is dry, now all of a sudden you can see cracks. You will be able to diagnose cracks. You will be able to treat cracks. So that's really a big advantage rubber dam isolation has for me. Now in this patient, like you can see, obviously I did not use rubber dam isolation. And unfortunately, this dental burr ended up in the patient's throat. Now, luckily, this patient actually swallowed this dental burr and it went right through the gastrointestinal tract. But imagine if this patient inhaled this dental burr, what situation I would have been in. And the funny thing about this patient is this patient didn't even want x-rays taken of their teeth before the restorative treatment was done. And you can imagine the situation I was in when I told this patient, now all of a sudden we have to take abdominal x-rays. So don't put yourself in a situation like this. Place rubber dam isolation, not just for root canal treatments, but even for restorative work. Now, the biggest tip I can give you all for rubber dam isolation is actually a course that I did. It's an online course by Dr. Charel Kotzé. the Rubber Dam Master online course. Now, it costs $129, which equates to about 2,300 Rand, but it's really worth it. If you are struggling to place Rubber Dam and you just want a basic course on how to place Rubber Dam and to get more confidence in doing Rubber Dam, especially even for restorative work, this is a great course which really set me up for success when placing Rubber Dam. It really gives you a nice workflow. It gives you tips and tricks how to place Rubber Dam. So it's really a great course that I would definitely attend and do if I'm struggling with Rubber Dam isolation. Moving on to our caries removal. Remove all carious and pulpal tissue. Now, this might not even sound like a tip, but I can promise you, in the beginning of our dental journey, we are so conservative because we don't want to remove unnecessary tooth structure. And it is important. We shouldn't remove unnecessary tooth structure, but I can remember in the beginning when I made my access cavity, or even when I did restorative work, I was really so conservative that I would leave a lot of carious tissue. So it's really important to remove all carious and pulpal tissue. Now let's look at the clinical case. This patient came in with pain associated with tooth number 27, and you can see there's actually an open contact, and there's the carious lesion. Now just see under magnification, you can physically see how nice and clean that cavity is. So I would really advise you guys to invest in magnification because it will really help you to physically see that your cavity is nice and clean. Because I can remember back at university that some of the older dentists would tell me, no, it's a feeling. You can physically feel if the cavity is nice and clean. You feel it with a probe, and you can sometimes feel it with a probe, but I don't want to guess. I want to really see if my cavity is nice and clean. Now, another tip I can give you all is that we usually clean our cavity out quite nicely on the gingival step, but the area that we often neglect removing carious tissue is up on the walls. That's really an important area to clean because the step, we usually clean that out nicely, but remember to clean your cavity up on the walls, not just on your gingival step. That's really important. And that's the post-operative radiograph of this tooth. And you can see with the aid of magnification, just see how nice and conservative we were with our access cavity. So we made a caries-driven access. We did not remove unnecessary tooth structure, but we could physically see that our cavity was nice and clean. Now, the reason why I say remove all pulpal tissue, we've all done a root canal treatment at university on an anterior tooth, or we've seen root canal treatments done on anterior teeth, and then a few years later on, the patient comes back and the tooth is a grayish or bluish type of color. And there's a lot of reasons why a tooth can discolor, but one of the big reasons is that we actually don't remove all pulpal tissue in the pulp horns. So when treating an anterior root canal treatment or doing an anterior root canal treatment, make sure that you actually remove those pulpal tissue in the pulp horns. But because what actually happens, that degenerates and it moves through your dentinal tubules and it causes the anesthetic appearance that our patients complain about. So just focus on that when treating anterior teeth, that you make sure that you remove all pulpal tissue. Moving on to our locating canals. Now, the pulp floor is your roadmap. Now, I can remember at university, like I said, we only had to do 5 molar root canal treatments. And the biggest drawback about university is that you don't get to do a lot of emergency root canal treatments because it's at your emergency root canal treatment where you actually usually locate some of the canals. Now at university, you just get a tooth that the emergency root canal treatment was already done. So you've already have your mesiobuccal canal, your distal buccal canal, and your palatal canal. Now getting to your first year of private practice, now all of a sudden, when a patient needs a root canal treatment, you actually have to get those canals. So what's really important is that the pulp floor is your roadmap. And the first tip I want to give you all, and it's actually very simple, but your pulp floor is not flat. That's really important because the mistake that I made in my first year And you don't want to use a drill like this. You actually want to use something like an Endo Z burr, which has a non-cutting tip. But anyways, what I did was I located one of the canals. And then what I did is I drilled from canal to canal. Now, as you can see, the pulp floor is not flat. So what will actually happen, you will perforate through your tooth. And that's exactly why I perforated that tooth in my first year of private practice, because I was drilling from canal to canal, forgetting that my pulp floor is not flat. It's actually round. So make sure that when you are searching for your canals, don't drill from canal to canal. Make sure that you remember that your pulp floor is rounded. The second important thing is where to locate those canals. Now, there's a great article written by Krasner and Rankow on the anatomy of the pulp chamber floor. Now, what's really important is that your pulp chamber floor is dark and your walls are white. So right in that area, that's where you want to search for your canals. So we're going to look at a few clinical cases and hopefully it will be more understandable for you all. So this patient was referred to me for a distal buccal canal that could not be located. And this is usually the mistake that we make. We drill too far away from the center of the tooth to try and get the canals. The canals are usually located in the middle of the tooth. And like you can see, that's where the canal was located. Now, I actually also almost perforated this tooth, but after treating this case, I read up on that article and it all started to make sense where to try and search for these canals. So looking at another upper maxillary tooth, this patient was referred because there was a lot of calcified tissue inside the tooth. And now I'm indicating with the probe in the areas that I'm going to search. It's where the darker pulpal floor meets your white wall. It's in that area that you want to search. So that was the MB1 canal, MB2 canal, the palatal canal, as well as the distobuccal canal. So like I said, canal orifices are located where the dark pulpal floor meets your white wall. So it's right in those areas that you want to search for your canals, because like I said, the mistake that we usually make with upper maxillary teeth is that, or molar teeth, is that we actually drill too far away to try and get our canals. Our canals are located in the middle of the tooth. So stay in that dark pulpal floor area. And when we look at mandibular teeth, the canals that we usually miss is the distal canals. So it's really important to know that there sometimes are two distal canals. Now, a tip I can give you all here is if you are treating your distal canal and you can feel that your hand files and even your rotary files, there's not a lot of resistance, you're most likely only dealing with one canal. But if you have a lot of you're putting in a lot of effort with your hand files and even there's a lot of strain on your rotary files, you're most likely dealing with a second canal. And I want to show you another mandibular tooth. That's the mesial canals. Interesting thing about this case, there was actually a mid-distal canal. So be very vigilant of the distal canals, because sometimes we think it's only one canal, but there could be two canals. Like in this case, there could actually be three canals. And this mid-distal canal actually joined the distolingual canal. Now, the other reason why I want to show you this periapical radiograph is look at tooth number 4-5. Look at that anatomy. Now, it's really important when taking periapical radiographs or even a panoramic radiograph, when you see weird anatomy on neighboring teeth, be sure that you will find some weird anatomy on the tooth that you are treating. So always keep that in mind. Moving on to our working length determination. Now, as you prepare the canal, it straightens and shortens. One of the biggest things I struggled with in my first few years of doing root canal treatments is I would measure my working length and I would use my rotary files and I would make sure that I would stay exactly on my working length. And then when I placed my GP into my canals, all of a sudden, all my GPs went right through the apex and I couldn't understand what was going on. But what's really important, like I'm saying here, as you prepare the canal, it straightens and shortens because not all canals are straight. Some canals are curved. And as you prepare the canal, you're actually straightening the canal, and now your working length is actually shortening. So that's really important, because as you straighten the canal, you are actually removing that dentine ledge. So just like you see in this case, when you are straightening the canal, you are shortening the canal. And there's an article that they wrote to see the effect of this, and they saw that in an unflared case, the working length was 22.43 millimeters. And after treating this case, the working length all of a sudden changed to 21.02 millimeter. That's a change of more than 1 millimeter in working length. So a tip I can give you is, after you've used your number 20 rotary file, before you use your master apical file, if that's a number 25 file or even a 30 file, just recheck your working length. Make sure that your working length did not change, because I can promise you it usually changed by 0.5 to even, like in this case, to 1 millimeter. And nowadays we have built-in apex locators into our endo handpieces, and this helps with a problem like this, because as you go down with your endo handpiece down your canal, the handpiece will actually short circuit before you actually reach that apex. So it will prevent you from over prepping your canal. But that's really important. As you prepare your canal, you're actually straightening your canal, and your canal shortens. So hopefully this will help you not to over prep your next case. Now moving on to our preparation of our canals. Our preparation with our hand files are very important. Sometimes we just want to rush to our rotary files because we think our rotary files will fix the problems that we could not fix with our hand files. Now, an important concept I want to explain to you guys is what we call a reproducible micro glide path. Now, that's a smooth preparation from the coronal part of the tooth to your working length that's reproducible by your successive files. And that's at least up to a number 10K file. Now, the biggest mistake I made when in the beginning of my dental career, when I started doing root canal treatments, I would negotiate with my K file down the canal. I would get to patency and my working length, and then I would pull out my file directly afterwards because I just want to measure my working length. And that's the stupidest thing that I could have done, because when I went back down the canal, now all of a sudden I can't get to patency anymore, or I even can't get to my working length. Now, what's really important when you add patency with an 8K file, or you add your working length, make sure that you stay in that area and you work hard in that area. You make sure that your file is nice and loose before you take that file out of the canal, because I can promise you to get back to that patency again and to get back to that working length is sometimes difficult. So make sure that when you add that part of your canal, make sure that your file is nice and loose, because you might not get a second chance. Another important thing is the difference between a K file and a C+ file. Now, we all know how to use K files, but C+ files are very nice to use in calcified cases where it's really difficult to negotiate the canals. Now, what I like about C+ files is that they are stiffer than K files, and they actually have an active cutting tip, which can cut dentine. Now, it's really important to know how to use these files, because if you don't use it correctly, you might actually cause more damage and do more harm than good. Now, I'm going to show you a video of how to use these files. On the left-hand side, you can see that's K files, and on the right-hand side, that's C+ files, and on the C+ file, on the handle, you will see there's a C. Now, with K files, you want to use on the left-hand side, you want to use the normal watch wind effect. That's what we all know how to use. But with C+ files, you want to feel for a sticky spot, rotate clockwise into that sticky spot, rotate out counterclockwise. So that's that type of motion that you want to use to try and negotiate difficult and calcified canals. Now, what's really also important is that you actually want to interchange between a C+ file and a K file every 2 to 3 millimeters that you gain in length. Don't just use a C+ file, because when you use the C+ file, it will actually open it up a bit more. And now when you use your K file, you will actually be able to progress even deeper. So interchange between your K files and your C+ files. That's really important. And you can see this root canal treatment that we did for this patient on tooth number 27. It's impossible to treat a case like this without the use of C+ files. And you can see with the use of C+ files and K files, we were actually able to negotiate all 4 canals to full working length. Moving on to our preparation with our rotary files. New files form. Now, I know we can't use brand new files for every patient that we treat because medical aids don't justify that. But if you want to take out a brand new packet of files, for which teeth do you want to use it on? And the answer to that question is when we actually look at Instagram. So when you search for file fractures or file retrieval, you can see that most of the cases that dentists and endodontists post on is similar. And it's usually fractured files in mandibular teeth. And if you look closely, it's usually the mesial canals of mandibular teeth. Now, this should get to start us thinking of why does most file fractures happen in the mesial canals of mandibular teeth? Because there must be something going on, because why does most of the file fractures occur in these teeth? And the answer to that question is when we look at the canal configuration. Now, the most common canal configuration that the mesial canals of mandibular teeth has is a Vitucci type 4, where it's 2 canals coronally and it exits as 2 separate canals. The second most common canal configuration that the mesial canals of mandibular molar teeth has is a Vitucci type 4, where it's 2 canals that actually join as 1 canal. And it doesn't really look something like this. It more looks something like this, where your mesial lingual canal is your straighter canal and your mesiobuccal canal is your more curved canal, and it joins the mesiolingual canal at an acute angle. Now you can imagine when you place a rotary file down that mesiobuccal canal, it will bind in that area and it will just fracture. So a tip I can give you all, if you don't have the aid of a CBCT scanner to see that these canals actually join, is to actually treat your mesiolingual canal first. Treat it up to your master apical file and then place a GP into that canal and then only place a K file in your mesiobuccal canal. Now you will see if these canals join, it will actually leave a mark on your GP. So another way that you can see if these canals join is with the aid of aspiration. So you can see we actually aspirated some sodium hypochlorite in this case. We aspirated in the one canal and it actually pulled up in the other canal. Now, this is not the most accurate way to see if these canals join because there could be an isthmus between these canals that can cause the same phenomena. So the best way to see it is with the aid of a GP into the one canal and a K file in the other canal. So I'm going to show you a case of a root canal that we did on tooth number 4.2 and 4.3 to show you how to do this. So both of these teeth had 2 canals, and tooth number 4.3 had 2 canals that joint. So like I mentioned, you treat the one canal, you place a GP into the other canal or into that canal and a K file into the other canal. And now you will see if those canals join, it will actually leave a mark on your GP. And now you can cut your corresponding GP to that length and you can just prepare that canal just to that length. And there you can see that's the post-operative radiograph of that tooth. Moving on to our irrigation. Now, the preparation of our files is only there to facilitate our irrigation. Sometimes we think of our preparation as of our files as the most important aspect of our root canal treatment because we think that's actually cleaning the tooth. Now, it is removing some of the infected dentine, but it actually just paves the way for your irrigation solutions to the apical third of your tooth. Now, it's also not adequate enough to just irrigate between files. You have to have a final irrigation regime. So after you've used your master apical file on all your canals, then you want to have a final rinse, because that's might be the only time you will be able to get to your apical third of your tooth. Now, the final irrigation regime that I like to do is to use sodium hypochlorite, EDTA, and then sodium hypochlorite again. So I would start off, like I said, with sodium hypochlorite. I would not use Molten, which is 1% sodium hypochlorite. It's not strong enough. So at least use something like Jig, which is 3.5% sodium hypochlorite. I would heat that up to about 40 degrees Celsius with my baby bottle warmer. I would irrigate with that for at least 2 to 3 minutes. And I will also try and activate that irrigation solutions in some manner. So the sodium hypochlorite will actually remove your organic component of your smear layer, which is your bacteria. Now you want to rinse with your 17% EDTA, ethylene diamine tetraacetic acid, and that will remove your inorganic component of your smear layer. That will actually open up your dentinal tubules to allow your final rinse with sodium hypochlorite to remove some more bacteria. So like I said, then I would rinse with 17% EDTA for about 2 minutes, and then my final rinse with sodium hypochlorite will not be too long. It will be about 1 to 2 minutes. Now, a way to actually activate your irrigation solutions, which is its cheap and effective way, is with the aid of manual dynamic agitation. So what you want to do is you want to grasp your master apical or your master GP, grasp it 1 millimeter short of your working length, and use that to agitate your irrigation solutions. And that's the appearance that you want to see in your canals. A nice milky solution. Now you know that your sodium hypochlorite and your irrigation solutions are doing its job. Moving on to our obturation. Now, most of us nowadays are using bioceramic sealers, and we are actually accustomed at university to using zinc oxide eugenol sealers. Sorry, we are used to using zinc oxide eugenol sealers. We are used to using resin-based sealers, but we are not really accustomed always to use bioceramic sealers. Now, what's really important about bioceramic sealers is to actually read your instruction manuals. Now, as you can see, this is a product by Wright Milners. It's NeoSealer Easy Flow. When you look at the clinical directions for use, just look at that. Moisture is required for setting. So that's really important, because most of our older sealers that we've used and we are accustomed to using, we usually want to dry out our canal completely before obturating the tooth. But it's really important that with bioceramic sealers, moisture is required for setting. So you don't want to dry out your canal completely. Now, like I said, when you're done with your final irrigation regime, you can actually clean out your canals completely with a paper point if you want to. But what I like to do then is I would take some distilled water. I would just dip a paper point in that distilled water, and I would just wet my canals a bit just to make sure it's moist and not completely dry, because these bioceramic sealers actually require some moisture for its setting. Now, what's also really important is that GP, it doesn't really do anything. It doesn't really seal your canal. It actually, the big function about a GP is that it actually just carries your sealer to the correct length. So that is the function of your GP. Your GP is there to carry your sealer to your working length. And it's not, the GP doesn't magically seal your canal. It's actually your sealer that will seal your canal. And then finally, we get to the end of the lecture where it's the restoration. Now, as you can see, the restoration is actually 50% of your treatment. The other 50% is your root canal treatment, but 50% of your treatment, and doing the root canal treatment, is actually your restoration, because your coronal seal is just as important as your apical seal. Because usually when we get to our restoration, we are tired, the next patient is waiting in the waiting room, and we just want to rush off. We just want to close that tooth. But the coronal seal is just as important as your apical seal. Now, a concept that I want to share with you all is a concept that we call immediate pre-endodontic dentine sealing. And that's doing the restoration before you start to irrigate with any irrigation solutions. Because there was a study done to see the negative effect that our irrigation solution has on our dentine bondability. And they saw that actually doing your restoration first improves your bond strength by 3 times more compared to rinsing with sodium hypochlorite and it affecting your dentine and then only doing your restoration. So that's really important. So I want to show you how to do that. So this patient was referred for a root canal treatment of tooth number 16. You can see there was pulpal tissue that we had to cauterize. We cleaned out the cavity, we packed Teflon, and now we're doing immediate pre-endodontic dentine sealing. That's before we even touch the inside of the tooth. So that's immediate pre-endodontic dentine sealing before we actually start to treat the inside. In this tooth, we also located the MB2 canal, and that same technique that I showed you to see where those canals join, we used in this case. And there you can see there's the MB2, MB1, there's the buccal canal, as well as the palatal canal. And this MB2 canal actually joined with the MB1 canal. That's placing bioceramic sealer. And that's after obturating this tooth. Now, what's also nice about placing your restoration first is that you will actually keep all the irrigation solutions on the inside of the tooth. You don't have to worry about it going down the rubber dam or down your patient's throat. And the other thing is when you actually obturate the tooth and you burn off your gutta perca, and you don't have a lot of sealer that's over your gingival step, and you don't have to worry about that. So that's really something important to do, is to do immediate pre-endodontic dentine sealing. And that's the post-operative radiograph of that tooth. And I want to leave you all with some food for thought. Strive for excellence, not perfection, because perfection causes pressure, doubt, and self-criticism. Whereas excellence is knowing that we will never be perfect, but that we are striving to be a better version of ourselves every day. As it's not about the destination, it's about the journey. And with that, I want to thank you all. And you can follow me on Instagram, where I share a lot of these cases and where I really try and share a lot of tips and tricks, even for restorative work. And you can take down my number if you have any questions, and that's my email address. If you also want to reach out to me, I'm more than willing to help anyone that needs extra tips, because a lecture can only be so long, and there's only so many tips that you can give in a lecture. But I'm really looking forward to hear from you all and to see how you guys progress with your endodontic journey. Thank you very much.
Right. Thank you so much, Dr. Kotzé, for such an insightful endo lecture. I mean, I think I've revived a lot of insight, but I've also gotten a lot of incremental steps that I think one misses in order to really achieve a good root canal treatment. Right. We're going to move on to the Q&A session, of which Dr. Hendrik de Penal will also be involved in. Sorry, doctors, there's actually just a question as well, just to open up the chat. Hopefully everyone in this chat room will also pop in a lot of questions. The first question is from Yushava Govender, and they are asking, how much does one charge for a root canal of a molar?
Not enough. I don't know if Dr. Heinrich want to comment.
Yeah, it's a difficult one to ask. I mean, sometimes get 4 or 5, depends on the retreatment, but I guess anywhere between 9,000 and it can go up to 14,000 Rand if it's a retreatment of 3-4 canals. And then you must be able to back yourself for what you do. But thinking what is the alternative, if you have to do a 3-unit bridge, can run up to 15,000, 18,000 Rand. If you're going to place an implant with a crown, you can run to 30,000 Rand easily. So, you know, the alternative is much more. So if you can back yourself and you do proper work and strive for excellence, as Charel said, then you should be able to charge for it, and don't be shy. And that is where all this helping tools. A microscope is not just a clinical tool. It's the one thing that if they take it away, I tell you now, I will stop practicing dentistry. But I think it's the most impressive communication tool that you can have. You know, if you show a patient, look how clean it is. Here's the canals. Here's a little crack. You know, just they see the extra effort that goes into doing it. And I think that justifies the price tag in the end. And that's where informed consent plays a big role, to speak to the patient beforehand and to give him a proper quotation or a breakdown and tell him this is the X, Y, and Z, not just based because you get a practice that work on medical aids only tariffs, and then it's difficult to charge these fees. I can relate to it, being also a young dentist. But I mean, if you now take any of the modern file systems, just a file, and I also work only on a one-use file system where I use it and I throw it away, so it only gets used on one patient. Now it's easily, if you start using that and you bring in a XP shaper or XP finisher, it can very easily add up to 1,500 Rand just in pure cost for that. So yeah, and if you only charge 5,000 Rand, there's no ways that you can justify it. And that's where there is a code that you can actually charge for it, and that's where you sit down with the patient and say, this is what your medical aid is going to pay, but this is my policy and this is what I charge. So don't sell yourself cheap.
Yeah, and I also think something that you want to do at the start of your career is you have to decide, are you going to do quality or quantity? So in the beginning of your dental career, if you want to really strive for excellence and really try and give the best treatment to your patients, you will have to be able to give a bit of money almost away and lose a bit of money, not necessarily do financially that good in the beginning of your career, but at least you're learning and you're learning how to do the treatment and the procedures correctly, but to the best of your ability. And as you get better and as you get more confidence, you will be able to do it quicker, but you will also then be more confident to charge more expensive fees because now you're seeing that your work is actually getting good results and you know that you're putting in a lot of effort and you're using the best equipment for your patients.
Yes. Second question I see is, what other files do you recommend? Well, normal K files would be my go-to, and not C+ files as a starter, because they bend quite easily, become more expensive, and I only use them selectively on very calcified canals. So either FKG or the Dentsply, the ready steel files, I think they are, in my opinion, some of the better ones on the market. The FKG ones is nice. The only problem I have with them is the handle is thicker, and if you use, for instance, a reciprocating handpiece, it can be a problem. Perfect Plus from Milner's is fine for what it does, but you can't overuse it, can't take the punch. And then other file that I've been starting to use, which I get from Inter-Africa Dental, it's from a company called Mani, M-A-N-I, and it's called D-Finder. So it looks like a cut-off circle, and that's why it's called a D. And I must say, in some cases where I really do struggle, even with C+ files, I've become quite a fan of the files. They get it in a number 8 and a number 10, which is also a nice file. And I mean, that's not the extent of a lecture, but the problem is a C+ file. The biggest difference is in the first 4 millimeter of the file. So just to break it down, if you take a 6 C+ file, it has a taper of 5%. So if you go 1 millimeter up, it would be the size of an 11 file, or an 8 C+ have a taper of 4.5%. So it tapers progressively, very aggressively over the first 4 millimeters, where a normal K file is a constant 2 millimeter file. And that's why it's easier to use normal K files like the ready steel file or a FKG normal K file. So C+ files is only really for those calcified ones. And like I said, if there's something else that you want to try, is the D-Finders from Mani, and you get that from Inter-Africa.
Sorry, Andre, I just want to quickly show something else. because that's also something that I didn't understand always how the files work with the numbering system. So I just want to quickly show you all this. And this is what Dr. Heinrich was talking about, how that taper is actually changing from the tip. And that's like a 2004 file, which the 20 equates to the 0.020 millimeter tip. But at 0.4 or 4% taper, or a 5% taper, or like with a K file, that's a constant 2% taper. That's actually what it means. So with a 0.4 taper, it's actually 0.04 millimeter increase in every millimeter that you move away from the tip of the file. So that's what Dr. Heinrich is talking about, and it could be a variable taper as well. It's not necessarily a constant taper like Dr. Heinrich said, yes.
Right. There's also an anonymous attendee saying, thank you for the extremely informative lecture. How do you deal with patients who express concern regarding the endo causing cancer, as some of the TikTokers are expressing on social media?
Yeah, that's always a difficult one, and you obviously get these greenies that will tell you all this or that, but that's the news where you have to back yourself to say, well, we worked on sound principles, and you can't compare the study that referred to what was made in 1933 about Carious or cancer in endodontics, and just to tell them that things have changed with the way that we clean it, and if you have a case or two, I think that's the best way to say, well, it's easy to say take it out, but did you know that implants is also not fail-proof, because everyone wants to take out teeth and they want to place implants, but to tell them that that's also not foolproof, that's one opinion. The other opinion is to show them the effect on, and I always tell my patients, well, we can save this tooth, and even if we can save it for another 5 years, look how much technology has changed in the last 5 years. So with that, you're winning 5 more years of technology with it, if there's not an alternative. And the one thing that I found that resonates very well with my patients is I tell them, if we take the nerve out, it becomes like your nail. So if you take your nail on your hand and you pull on it, it's sore because it's embedded in the nail bed. But you can knip it with a knipper and there's no pain. And the same is going to happen with your tooth. Is you're going to clean it out. The tooth itself won't have pain, but it still has a periodontal ligament which functions normal, which shows you that there's food stuck in between there because you have proprioceptor fibers from that. And I must say, I found that when I tell it and explain it to them like that, they like the correlation of a nail to say, but it's still something healthy. There's a part of it that's still working, but the tooth itself is going to be dead. But there will be the 1 or 2 guys where you will never something, and then, well, the alternative is to take it out. But I do find that works well.
Right. Dr. Kotzé, do you have anything to add to that?
No.
Okay, the next question says, thanks, Charles. Great stuff, man. My question is, where do I do my diploma? I heard UP doesn't do it anymore.
Yes, I think they do.
I think they still do, but they are struggling. They probably, after this year, because of Dentsply that pulled out, or some of the companies that were on tender have moved away, and they don't do it at the university anymore. And they probably will do it privately from next year. But you can reach out to, you can Google or on his website to Prof. Piet van der Vyver or Martin Foster. I know they're still actively involved and they are busy with it this year, but I'm not sure whether it's going to continue in next year. And as far as I know, Western Cape also have a 2-year endodontic diploma with, Dr. Charlene.
Right. And another question is, pardon, Doc?
No, Charlene Simon, but I know she's also on the edge of retiring, so I also don't know whether that is going to continue, and whether with Martin being in Cape Town, whether he's going to continue at Western Cape.
I know, but hopefully they will. Right, the next question is, hello, thank you for this presentation. I'd like to ask, if a patient returns that you treated obviously previously with a complaint and describes what the issue was, how do you manage it? I'd like to ask if you recommend, also she asks if you recommend any loops for newly graduated dentists. Thank you.
Yeah, so just to get to that first question, yeah, it depends on what the problem is, how the problem will be treated. But definitely the loops that I used in the beginning of my dental career was Zumax loops. So you can contact David Dubell. The big thing about Zumax loops, you get a lot of help from David Dubell. He's really informative and he can help you to set up the Zumax loops. And so you get a lot of support from them. And then as you progress, you can invest in more expensive loops. So I actually bought loops from Israeli company, Admetech, which I'm really glad I did. So, and I use that more for restorative work. It's about 7.5 magnification, and it's that refractive or ergonomic loops. But it's really an adaptation in the beginning. But as you get used to magnification, it really almost gets an addiction. So because as you see, you can see a lot more detail. You just want to see more. So in the beginning, I would definitely use something like Zumax loops because it's really a great loop to use in the beginning of your dental journey. And you have a lot of support. So if something breaks or if you struggle with something, David Dubell is always there to help you. You can always call him, you can always WhatsApp him. So that's the type of loops I would definitely recommend at the start of my dental journey.
Right. And the second question, the part of the same question, I think she also corrected herself. She says she wanted to ask regarding one of the patients. So she's treating a returning patient with a complaint. And she wanted to know from you guys, how do you guys deal with it after or just during the situation?
I think it depends on what the problem is or what the pain issue is. If I would strongly advise that if it's endodontic related, is to maybe, if you don't have one yourself, send it to a colleague that can just take a small field of view CBCT scan, because that's, if everything looks fine on the x-ray, you found the canals, you seal them off, that's the next step, because there is unfortunately a lot of the canals that's being missed, or when a fracture line or something else that you might pick on a CBCT, which you won't see on a and on a normal periapical. And maybe just the first thing is to look at the bite. And, I always warn my patients, listen, for the first 5 days, expect pain. If it's not, then it's all right. So then they don't call you because it is normally tender. Maybe prescribe them with ibuprofen or something post-op just to ease it and make sure that the tooth is out of the bite. Because when they are numb, they've been lying for hour and a half, their jaws might not function properly and their bite skews. So first thing I normally do is just take the bite, take it out of the bite, and that's normally their first complaint. If it's severely throbbing or paining still, it might be in need of some antibiotic treatment post-op. I would definitely take a CBCT to delve further.
Right. Thank you for that answer, the doc. The next question is, how can one improve the coronal seal after an emergency root canal? Is it calcinol or zinc oxide Eugenol? Is it adequate?
Yeah, it depends on how much time you have, but I usually try to do my a composite restoration if it's a class 2, at least a composite restoration, and then I would place a temporary restoration just at the occlusal aspect of the tooth. If you want to place something like calcinol, definitely then try to get your patient back in at least 1 or 2 weeks' time, because those patients usually disappear and they don't come back, and then you get coronal leakage again, and then you get all of the bacteria from the food that the patient's eating and from the mouth, then you get reinfection again. So I usually try to do that immediate pre-endodontic dentine sealing at the emergency root canal treatment step. But it takes a lot more time because now you can't just necessarily just do single tooth isolation with your rubber dam. You have to do quadrant isolation and isolate a few teeth. So it takes more time, and medical aids, they don't cover for a rubber dam isolation. We have emergency root canal treatment, so that's also sometimes a problem, but that's what I usually try and do. And even if I then don't necessarily ask for the rubber dam isolation, at least I know I've made my the work for myself much easier. So when the patient comes back, I can just do single tooth isolation, and now I don't have to worry about building up the wall again. And it's sometimes the first time to do a proper restoration is sometimes the easiest. Just do it right there and then when everything is nice and clean.
Right. And the next question is, do you use endo handpieces with built-in apex locators? Are they recommended, and how does one use them? Also just mention if there's any brand that you would recommend.
I think
It's a big game changer. I can't work without it anymore because they are dead on accurate. I think as technology have progressed, the time that it saves for you, that you don't have to sit with every file doing recapitulation, measuring on the X-ray, you just go down and you can put it on auto reverse. As soon as it touches on the apex, it reverses itself. So it's a game changer. It's a bit difficult to just say in a few instances how it works. It works just with the apex as an apex locator, except for it works while you're drilling down, and you preset it to say stop or start. And that's the amazing thing about it is you can put it on reverse. So as soon as it reaches your apex, it will come, right back out. And if you've prepped the canal wider, I sometimes go over to the stop mode just to check your length, or if you want to check yourself, because in the beginning I find that if you put it on stop mode, it engages on your file and it's sometimes difficult to get it out. But then you can go down, it will stop immediately at the apex. You put your rubber stopper down and you can measure the length without having to have a hand file. But it also comes with a little Y cable, which helps you to measure with a hand file. And the ones I would recommend, the one from Perfect that Molners is selling, is a very nice one. The woodpecker from Vision is also very nice, and then the FKG one from Access Dental. I think that's the first three that comes to mind, which are really great. ATIV is also a nice brand, but they've changed hands so many times. I'm not sure. I think they at Henry Schein might be, but they all are really doing the same thing. I've tested all of them, and they are really are great. It depends just on the speed of them. Some of them, like the more expensive ones, can spin at 3,000 to 2,000 RPMs, where some of the other ones spin at a lower rate. And then I know the entry-level one of FKG versus the more expensive one is you have to change cables. You have a cable that you plug into the handpiece if you want to measure with a hand file, or you have to plug in a different cable if you want to work with the file, where the other bands have like a Y cable that works. And then Dents by Serrano also have one, but I don't like it because you have an extra cable on the unit which you have to put very close to you where you work, where this is a normal handpiece, very nice and small, and you can literally put it on the patient's chest and change files. It's very easy to work with. Yeah. And you can set different beeps to what's accustomed to your ear and what you wanted to do. I have the new Perfect Plus one. It actually has nice bars that flickers up and show you in color, where you are. Are you in the middle of the canal? Are you closer to the apex? And there's another one from Woodpecker that's a bit more expensive, but it comes with like a smart watch that's on your wrist, and while you work, it will give you information that you can look like a watch on your wrist to show you where you are in the canal, or give you feedback on that. So yeah.
Doc Kotzé, do you have anything to add to that? That was a lot of insight, eh? There's actually quite a big variety. The next question is, what is your go-to sealant, I think, / medicament for a periapical abscess that is not healing? They say the patient returned for a second visit and the canal was still bleeding.
Normally bleeding, just normal calcium hydroxide should do the trick. You place it in, but it also comes in with questions of a little bit backwards where it was we have to seal it properly, get 4 walls. Otherwise, the canal, just quickly take a Toffelmeyer even. If you don't get to build the contact, especially most of these teeth need the crown later, then you can sort the contact out, but get 4 walls, seal it properly so that your intermedicament can work. So calcium hydroxide, yes, or rinse it with a bit of local, and then leather mix are still, for those very severe, painful, acute pains, they seem to be the go-to. And if there's a big area draining, we use something that's called dry paste, which is 3 antibiotics that you mix. You can Google it and see. So you take ointment from Dental Warehouse, which is, it has ibuprofen in it. It's called Odonto paste. And you mix that with ciprofloxacin, metronidazole, and can't remember the other one, minocycline, and you mix the 3 antibiotics. So I have my pharmacist just mix me powder in, and I mix it, and I use the Odonto paste as a medium in which you can spin it in, and it helps really to bring the pH down of that severely abscess cases where there's a lot of drainage. And another silly tip is don't put cotton pledges, the one that asked about should you use calcinol or what should you use as a temporary filling. So you use your 4 walls and it puts plumber's tape underneath it. Pack the whole cavity with plumber's tape. It gives you a much stronger foundation and it seals the cavity, the pulp chamber off better than cotton pledgings. So firstly, you don't get crevicular fluid coming down, and also it helps that your medicament can work better. And I found that if you condense it and then put a little bit of STR or calcinol over it, it doesn't break out as easily. And you know that patient that comes in Friday afternoon, 4 o'clock, and now it's draining and it's weekend, and that's the guy who's going to phone you. A silly thing that I sometimes do, those odd cases where it's draining and you can't get control and you're out of time, is I take plumber's tape and I put my medication on, I fill the whole tooth just with plumber's tape to the top. If you condense it in, there's no way it will come out. You take the tooth out of the bite. I show the patient what I do, and I give him a probe and I give him a tweezers to take home. And I say, listen here, if you feel that this pressure buildup is not, take the probe, just nick it, and you will pull that whole plumber's tape out, and it's open, and then you rinse it with salt water every hour until the pain subsides, so that he doesn't come in and, bugs you over the weekend. So that's what I sometimes would do, is just plug it full in one piece. Don't put little pieces in. You take it, you plug it until it's done, condense it in. That's it. In those severe swollen or cases where you are scared of, it's a nice clinical tip that really helps.
Wow. Okay, that's definitely very new. And the next question.
I just want to also mention it's quite important about calcium hydroxide is to when you place it, be careful. Don't place it through the apex because it can cause necrosis. So when placing, especially your ultra cal, that white calcium hydroxide, just be careful and make sure that you are placing it 1 millimeter short of your working length, that you don't push it through the apex because it can cause necrosis. But
Right.
a calcium hydroxide with iodoform in, that's more that yellowish type of calcium hydroxide. That's all right if you get it close to the apex or if you get it a bit through the apex. But definitely a white calcium hydroxide, you don't want to push that through the apex. Yes.
Yeah, something like Vitapex, yes.
Yes, yeah.
Right, and the second last question is separated files. How do I break the news to a patient without breaking down yourself? Always a sinking feeling when it happens. Is one of the doctors going to give some input? Because I know when that happens, it's such a dooming feeling. You don't know where to go, but I think the first thing is to inform your patient.
Yeah, what I normally tell patient auditors, or you get referrals, and you never want to throw in someone underneath the bus. I just always tell them, listen, this is one of the complications that can happen. I show them the files beforehand and say, listen, this is very delicate and we might struggle, and we'll do everything we can. But if it happens, I show them. I say, listen, in the old days they did apicectomies where they cut open the bone, they put metal and amalgam at the apex and it didn't do anything. You have metal screws going in. So the file itself that fractures off can't do any harm. There's nothing that a file that separates can do. The problem is in what time of your treatment it fractures. Because if it fractures and it blocks you from regaining access, then you can't irrigate and you can't clean properly, and then it can become a problem. But I always just try and maybe sugarcoat it a little bit to show them, listen, we've cleaned it out, we managed to bypass it, or if it's in the beginning and there's pain, then you should, if you're not in a position, to refer it to someone that can take it out, or ask the patient, well, this is one, but that's just where the informed consent to them, maybe just tell them that, listen, this is one of the complications that can happen. It is not the end of the world, but it might hamper our success rate. So if it happens, I will tell you, but we're going to try, to avoid doing it. And this is again why we use new files, but it is a complication that happens from time to time. That's about it. You can't say there's not much more that you can say, but I think just to ease it and say, oh shit, I think your own reaction is just to be calm. And although we all feel bad, and if you haven't fractured a file, then you haven't done enough root canals, because it happens to everyone, skilled practitioners, beginners. It's one of the complications that happen. But just to say, well, it is something that happens, and it's not the end of the world. It's a file. We still clean. We're going to seal it off, and we'll take it from there. That's how I would manage it.
Right, we've come to our time where we're going to do our closing remarks. I'm just going to conclude it with a comment by Dr. Adnil Nakia. Says, hi, Adnil here. Great lecture, Charles. I would temporize any composite with any composite that you do have. Use Teflon, not cotton pellets. I think Dr. Pinar also mentioned that. It is a nightmare having temps fall out and coronal leakage. You end up spending all the money you would have saved by using something like Cavit, Carlton Oil, or IRM, right? I'd like to thank our speakers for guiding us through the small, intricate journey of your endodontic dentistry. I think I've learned a lot, and I can definitely say our attendees definitely received a lot of insight. Is there anything that you'd like to say as a closing remark as we conclude this YDC webinar?
No, I just want to say thanks for the opportunity, and thanks for everyone. I don't know how many attendees are still here, but thank you for being here, and it was a privilege to do the presentation. And yeah, the industry is not easy. Dr. Heinrich and I also spoke before the start of this lecture. It's really something that can consume you quite easily. So we don't have to be too hard on ourselves. The industry is difficult, and root canal treatments is definitely difficult. And most of the stuff people share, even on Instagram and social media, is usually our best cases, and we don't always share our mistakes, but we all make a lot of mistakes, and I think we can just all learn from each other, because we learn more from our mistakes than we actually learn from doing an perfect endo. So that's really something that we need to focus on, is that we're gonna make mistakes, but we can learn a lot from our mistakes.
Right. And Dr. Pinar, do you have any closing remarks?
Well, the first investment I will do as a young dentist is invest in a microscope, and if not, in loops. I can tell you now, I'm blessed in a practice where you have everything from CEREC to CBCT, etc., lasers. But the thing that changed my practice, and that is one thing that one has to realize, is you buy a microscope for yourself. You don't buy it for your patients. Your patients benefit from it. Being 24 years down the line, we all are young, and you think you're untouchable. But believe me, the back aches, the neck aches, and all that comes after time. So we had one of our lecturers at Stellenbosch, he always said, I'm going to say it in Afrikaans, hy het altyd gesê die 12de gebod is keer vir jou lyf, and never understand it until you get older and you realize he's wrong. So invest in good posture, in good eyesight, because down the line, you still want to be able to enjoy it, and it opens up a whole new world for yourself. People think, oh, I must buy the microscope. Leave the car, all that will come with time. You're going to enjoy your work at most. It really, everything that you do is going to be different. And that for me, in my 24, 25 years of practice, was the best teacher that I ever had, because you can see your mistakes, or you can see things that you would have treated otherwise, where you can see that fracture that Charles showed, that you would have spent 2 hours on trying to save it just to be extracted and later find out it was a crack. It really is the best communication tool, and for me, one of the best practice builders. You're at the beginning of your practice, invest money therein, you can charge for it, and you will get every cent back. And the best thing is that it will make your life easier, and it will make you enjoy dentistry. It's probably a 4-week learning curve, but after that, you will forever be grateful. And yeah, good luck for everyone out there.
Right. Thank you so much, Doctor. And to the remaining Q&As, you'll be able to get the information on the lecturers. I think Dr. Charel Kotzé shared his social media pages if you have any question or inquiries. And I think also Dr. Hendrik Canal will also have. You can swap those in, and then they'll be able to sort of answer and be able to give you your answers then. Right. This is the YDC SADA webinar, and we'd like to thank everyone. Hey, have a good night further.
Bye-bye.
Thank you very
Bye
much.
there.
Thank you. Bye-bye.